Welcome to this explainer, where we're breaking down a monumental shift happening in modern surgical protocols right now. For literally decades, traditional postoperative opioids were the unquestioned gold standard for pain management on the wards. I mean, it was just what we did. But today, we are moving rapidly away from them. Instead, we're pivoting to ERAS, enhanced recovery after surgery, and multimodal analgesia. If you're a medico, understanding this paradigm shift isn't just about passing your exams, though. It's definitely going to help with that. It's really about fundamentally changing how we approach patient recovery and safety.
All right, let's look at our clinical roadmap. We've got 1. The post-op opioid crisis. 2. The addiction loop. 3. The ERS protocol shift. 4. The multimodal analgesia arsenal. 5. The regional anesthesia revolution. And finally, 6. Opioid-free clinical scenarios.
Section 1. The post-op opioid crisis.
So let's start with a number that is frankly alarming: 70%. Let that sink in for a second. 70% of new opioid addicts actually kick off their addiction with a simple, routine surgical prescription. That means the healthcare system itself, specifically our postoperative care, has inadvertently acted as a massive gateway to the opioid epidemic.
To put that into real-world perspective for your daily ward practice, of all your surgical patients given opioids, about 5 to 8% will go on to develop persistent opioid use. Think about that volume. If you're operating on hundreds of patients a year, that translates to dozens of people developing a long-term dependency simply because of the standard post-op pain protocols we all used to follow.
And look, even if we set aside the severe risk of addiction for a moment, we still have to deal with these 30-plus classic side effects acting as literal roadblocks to a patient's recovery. We're talking severe nausea, vomiting, dangerous respiratory depression, urinary retention, and that intense pruritus driven by histamine release. And of course, the absolute bane of every surgeon's existence, the dreaded post-op ileus. You desperately want your patient eating and moving, but the opioids are literally freezing their gut and tying them to the bed.
Section 2. The opioid addiction loop.
Medicos, let's quickly review the receptor pathophysiology here. We all know and love the mu receptor because it gives us that incredibly potent analgesia, but it is a massive double-edged sword. That exact same mu receptor is also driving the euphoria, the respiratory depression, the constipation, and ultimately the dependence that triggers the whole addiction cycle. Meanwhile, kappa and delta offer some analgesia, sure, but they drag along their own baggage, like dysphoria.
Let's trace how this positive reinforcement loop actually works in the brain. When the opioid binds the mu receptor, it triggers this massive release of dopamine right in the ventral tegmental area, or VTA. This hits the nucleus accumbens, which is basically the brain's ultimate reward center, creating intense euphoria and relief. But here's the catch: the brain adapts. Receptors downregulate. The patient suddenly develops tolerance and needs way more of the drug just to get the same baseline effect. And when they finally stop, a vicious, agonizing withdrawal cycle kicks in.
Section 3. The ERS protocol shift.
So what's the way out of this mess? Enter ERAS, or Enhanced Recovery After Surgery. This is a comprehensive, multidisciplinary approach that completely tears up and rewrites the timeline across the pre-op, intra-op, and post-op phases. Preoperatively, we are hyper-focused on patient education and optimizing comorbidities. Intraoperatively, it's all about minimally invasive laparoscopy, short-acting anesthetics, and strictly maintaining normal thermia. And postoperatively, we get them eating early on post-op day 0, ambulating by day 1, and crucially, we manage their pain using multimodal analgesia without the opioids.
And we are totally abandoning some heavily ingrained medical dogma here. That classic NPO past midnight rule for prolonged fasting, it is completely out the window. Instead, ERAS favors carbohydrate loading just 2 hours before surgery. Why? Because this keeps the patient out of a catabolic state, drastically reduces insulin resistance, and essentially primes their body to heal rather than starve. It's a total game changer.
The clinical proof of this protocol is honestly undeniable. By adopting ERS, hospitals are seeing a massive 30 to 50% reduction in hospital stays. And even more importantly for our focus today, it drives a 50 to 80% reduction in opioid use. Patients recover faster, they deal with way fewer complications, and the best part, they go home without a dangerous bottle of narcotic pills.
Section 4. Multimodal Analgesia Arsenal.
So how do we actually pull this off? The absolute crux of multimodal analgesia is this central thesis right here. There is no single perfect analgesic. If you rely on just one magic bullet drug, you inevitably have to push the dose so high that you practically guarantee toxic side effects. So instead, we combine different drug classes at lower doses. By doing this, we attack pain pathways from multiple different angles, creating a beautiful, synergistic effect while minimizing the nasty side effects of each individual drug.
Okay, here is your high-yield ward survival guide for the actual drug classes. We rely heavily on NSAIDs, like Ketorolac, which you'll often see under the Indian brand name Toradol. It's the strongest NSAID for acute pain, but remember, cap it at 5 days to protect those kidneys. Then we layer on IV paracetamol, like Parafulgon, keeping strict to that 4 gram per day hepatic limit. Next, we bring in gabapentinoids, like Pregabalin, to dial down the nerve sensitization, and alpha-2 agonists, like Dexmedetomidine, which gives us this amazing opioid-sparing sedation, particularly in the ICU. And I really need to highlight ketamine here, because it is a massive player. This specific sub-anesthetic dose of 0.1 to 0.5 milligrams per kilogram IV is a mechanistic pearl you absolutely must commit to memory. At this low dose, acting as an NMDA receptor antagonist, it doesn't actually put the patient to sleep. Instead, it provides incredibly powerful opioid-sparing effects and literally prevents the central nervous system from becoming sensitized to pain.
Section 5. Regional Anesthesia Revolution.
Now let's match some specific regional blocks to their ideal surgical use cases. Epidurals are still the gold standard for your major abdominal or thoracic surgeries, giving you excellent pain relief and letting the patient get out of bed early. Tap blocks? Perfect for laparoscopies and C-sections. Spinal anesthesia utilizes some really clever intrathecal opioid-sparing combos for lower limb and pelvic surgeries. And please, never underestimate the power of simple wound infiltration with bupivacaine. It's cheap, it's simple, and it buys you a solid 6 to 12 hours of post-closure relief.
All right, time for a super high-yield pearl, especially for those of you prepping for NEET PG or the boards. Burn the exact anatomical boundaries of the tap block into your memory right now. The transversus abdominis plane block is ultrasound-guided, and you are injecting the local anesthetic precisely between the internal oblique and the transversus abdominis muscle layers. Don't forget that one.
Section 6. Opioid-free clinical scenarios.
Let's pull this all together and walk through a standard laparoscopic cholecystectomy so you can see this multimodal layering in action. Pre-op, you hand them oral pregabalin and paracetamol. Intra-op, the anesthetist drops in a tap block with bupivacaine. Post-op, you are scheduling IV paracetamol and Ketorolac every 6 hours on the dot. You only touch the opioids as an absolute emergency rescue if the pain score shoots above a 7. And the result of this protocol? 90% of these lab col patients are discharged the exact same day, completely 100% opioid-free.
And hey, this isn't just a trick for minor day surgeries. Even for major abdominal or colorectal operations, we employ an epidural-based opioid-sparing pathway. You start with pre-op pregabalin and dexamethasone, followed by an intra-op epidural that just seamlessly continues as an infusion post-op, all alongside scheduled IV non-opioids. And because these patients aren't heavily sedated by narcotics, they are up and mobilizing on day 1, they're taking oral feeds by post-op day 2, and they are discharging safely by day 4 or 5.
And here is a beautiful downstream effect. Stripping away the opioids means we are also stripping away one of the surgeon's biggest historical headaches, the classic post-op ileus. You know, we used to just accept that the bowel naturally went to sleep after surgery. Well, now we know that post-op ileus is primarily an opioid effect paralyzing the gut. With ERAS, early feeding, early ambulation, and zero opioids, it means far, far faster bowel recovery.
So given these absolutely remarkable clinical outcomes, shorter stays, way faster bowel function, and literally 90% of routine lap chole patients walking out the door without a single narcotic in their hand, we really have to ask ourselves a serious question. Is the routine, traditional post-op opioid prescription finally a thing of the past? For us medicos, the data is loud and clear. The future of surgery is multimodal, it is enhanced, and it is entirely opioid-free. Thanks for joining me on this explainer, and I'll see you guys in the next one.